So the average surgeon is only going to get one or two of these questions right. And so if you get one or two right and the rest wrong, you're pretty average. If you get 3 to 5 questions right, you're probably the top 1% of all spine surgeons in terms of knowledge about the cervical spine radiculopathy. If you get 6 to 10, I would say, wow, you're a genius. I mean, I would expect Griffin, having spent a year with me and being the phenomenal surgeon and incredibly smart guy that he is, to get maybe about 6 or 7 of these right, less than half. If you get more than 10, you saw the answers. You already took this test, and there's no way that you're going to get more than 10 answers. There's nobody in this group, I doubt, that will get more than 10. So with that preface, let's go on and see the answer that you get for this. All right, so question number 1, which level causes radicular pain? So this is a person who says, I have pain in my armpit and over my chest, over my anterior chest. Is that coming from the C4-5 level, the 5-6, the 6-7? Can any of these levels give you pain in this area? And do none of these levels give you pain in this area? Am I just making this up? So let's see if you know the answer to that. So just write down the answer for yourself. The answer is C6-7. And this has been called cervical angina because it often presents to the emergency room with somebody complaining about chest pain. And they will say, you know, I have severe pain here. I went to the emergency room. They admitted me. They got an EKG on me. They got a chest X-ray. And then they told me everything was normal with my heart, and it had nothing to do with my heart. And in fact, what this is a C7 radiculopathy. I don't think I've ever seen this with a C5-6 level problem, but it can exist. And very rarely, C7T1 can cause problems. But if you see somebody that's complaining about anterior chest pain, the most common level is a C6-7 level. Which finger is never a C7 dermatome? In other words, which finger never goes numb if you have somebody who has a C7 dermatomal area of numbness? Is it the ring finger? Is it the thumb? Is it the small finger? Or is it none of the above? So the answer is that any finger can be numb when you have a C6-7 radiculopathy. I have seen patients with the thumb just being numb, the index finger alone, the long finger alone, the ring finger alone, the small finger alone, the last 3 digits, the first 3 digits, the middle 3 digits, the middle 2 digits, you name it. The C7 dermatome is the most variable dermatome. And so any one of these levels can give you a dermatomal numbness. And that's what's so confusing about this, because when I first went into practice, I would see somebody with the thumb being numb with a C6-7 problem, and I would sit there and say, well, this can't be. The textbooks say that that's a C6 radiculopathy. So what's going on? Maybe the person is making it up, but it is not. This Netter diagram that you see and whatnot is absolutely incorrect. All right, question number 3. Which level causes pain behind the mastoid process? Let's say this is the left side. Rotating to the left side hurts more than rotating to the right. And rotation hurts more than looking up or down. And it's just right behind the mastoid process, just at the bottom end of the mastoid process. Is it C1-2? Is it C2-3? Or is it C3-4? The answer is that it is the C1-2 level. This is a very common thing. Every year, I will see several patients with this. And every year, just about every fellow that goes in to see the patient first and comes out will make the mistake and say, oh, I think the patient has a C5-6 radiculopathy or C3-4 radiculopathy. I've seen 2 patients that have had surgery at levels other than C1-2 for this problem. One patient, I think, had 2 different operations and asked me, can I sue my surgeon for doing 2 operations that did nothing for me? And as soon as I came into your office, you said, it's your C1-2. And then you fixed it and the pain was gone instantly as soon as I woke up. And that can happen in patients because these patients usually have severe spondylosis. You can see this patient has an autofusion at 2-3 and 3-4, and their 4-5 is very spondylotic. And you usually don't get an open mouth odontoid view, you don't get a CT scan, and you don't look at the parasagittal MRI images. So you sit there and say, okay, you look like you're autofused here, and that's why you're having issues. And so your problem is here. I'm going to do an ACDF at that level, take care of your pain. Pain doesn't go away, patient's upset, you feel terrible. The most common reason for this is osteoarthritis, but you can even have rheumatoid patients have it. Gout, pseudo-gout is another very common thing that causes it. The key is where the pain is located and the fact that it hurts on rotation more than looking up or down. It's only one spot. Sometimes they will complain of pain in the greater occipital nerve distribution in the posterior occipital region, but this is very debilitating and it responds very nicely to a C1-2 fusion. The vast majority of these patients will wax and wane, but eventually there isn't much that you can do about this other than surgery over time. Okay, a similar distribution of pain, but it's a little bit bigger, and it goes behind the ear and all the way behind the eyeball. Is that C1-2? Is that C2-3? Or is that C3-4? Well, it's a similar area, but this one actually doesn't get worse with rotation as much as looking up with a Spurling's kind of a maneuver typically, but sometimes there's no Spurlings, it just hurts in the temple and behind the eye. Pain behind the eye is most commonly a C3 nerve root distribution area pain. I first learned about this when I was at the Cervical Spine Research Society meeting maybe about 15 years ago. And Henry Bowman, who was my fellowship director and mentor, and I were sitting there together. Bruce Northrup was the president of CSRS at the time. And the presidential guest lecturer, and I can't remember who it was, but it was a neurosurgeon who was giving a talk about high cervical radiculopathy. And 15, 18 years ago, most people didn't know about it. Henry Bowman turned to me and said, I never knew that. I saw so many patients with that. I had no idea what that was. And then afterwards, we went back and we saw some patients with that. He did an ACDF, and it cured the problem. I've done foraminotomies for this problem. I've done ACDFs. I've done anterior foraminotomies without a fusion for these, and they do work very nicely. And if it is at the C2-3 level, it'll go behind the eyeball. And so this is just a high cervical radiculopathy. Okay, which nerve innervates these intrinsic hand muscles? The abductor pollicis brevis, raising your hand up in this direction, opponens, the flexor pollicis brevis, and the lateral lumbricals. Is it A, the ulnar nerve? B, is it C7? Or C, is it C8, T1? And so this is a question that many surgeons don't know about. And it's something that you do need to know about. So it is C8T1, it's not the ulnar nerve. In fact, it's the median nerve. Those are the only median nerve innervated intrinsic hand muscles. And they are the only 4 exceptions to the rule that all intrinsic hand muscles are innervated by the ulnar nerve. And so we say that they are above the law. What does that mean, above the law? It just means that these are the only intrinsic hand muscles that are innervated by the median nerve and not the ulnar nerve. So ABOFL, above the law. Law says all intrinsic hand muscles are ulnar nerve innervated. These are innervated by the median nerve from C8 and T1. And why is that important? Because when you see somebody with hand weakness, you have to determine, is it coming from an ulnar nerve problem? Or is it coming from the cervical spine problem? I know so many people that have had their ulnar nerves released and other people that have had cervical spine problems when the problem is the ulnar nerves released when the problem is in the cervical spine. So if these muscles are weak, it can't be just a cubital tunnel syndrome because these are median innervated muscles. So you got to know which intrinsic hand muscle weakness comes from the median nerve and which comes from the ulnar nerve. And that way you will know whether it is coming from the elbow or the neck. And I've got other questions later on the elbow or the neck. Which nerve extends the fingers? Is it C6, C7, C8? Or is it D, which is A and B? Or is it E, C7 and C8? So extension of the fingers, if you have, why is this important? I test the extension of the fingers in everybody. It's because sometimes the bigger muscles, the patients are so strong compared to you that, at least compared to me, so that you can't overpower them when you're testing large muscle groups. But you can take a 250-pound all-muscle linebacker or UFC fighter, and you can still test them, and you can beat them when they're trying to extend their finger. And so this is one good test to see which nerve, if this nerve that is involved is weak. So when you take a look at finger extensors, it's done by extensor digitorum communis, which is a posterior interosseous nerve. It's a branch of the radial nerve. It comes from C5 all the way down to T1, but predominantly it comes from C7 and C8. So if you see somebody with a finger extensor weakness, most commonly it's a C7, C8 radiculopathy. So the next time you see somebody with a C7 radiculopathy and you test their triceps and they still seem pretty strong, and you test your finger and you go, wow, look at that, I can't keep it up. The other side I can keep it up, but this side I'm so weak at it. You'll be able to show that they have significant weakness. The other muscle group that allows you to do that is your lumbricals, because your lumbricals allow you to have the interphalangeal joint intact like that, and it bends the metacarpal phalangeal joint like that. That's what your lumbricals allow you to do. And so if you can't do that, your interphalangeal joint is your lumbricals. So if you test down here, you're testing your lumbricals. If you test up here, you're testing your extensor digitorum communis. So, but basically, it's the C8 and the C7 nerves that tend to give you the weakness. So, back to the question, it is E, both B and C. But because the C7 radiculopathy is so much more common than a C8 radiculopathy, you will see it much more commonly with the C7 than C8. Okay, let's go back to that head again and say, which level causes radicular pain behind the ear going up into the temple, but not so far as the eye? And again, this is a Spurling's maneuver, not rotational. Is it C1-2? Is it C2-3? Or is it C3-4? And this one you should be able to get by process of elimination, because we already had a question on C1-2. We already had a question on C2-3. So since you should have a 33.33% chance of getting this right, but if you were really paying attention to the other questions, you'd say, well, I saw the other ones, and it's obviously not that, so it must be by process of elimination, the C3-4 level. And sure enough, you'd be right. So this is one of those things you should be able to get just by test-taking skills. Yeah, patients with a C3-4 radiculopathy will say, it hurts behind the ear and comes up to my temple. Doesn't go as far as the eye. Now, there are some people with a C2-3 that'll complain about this, and there are some people with C3-4 that will complain about behind the eye. But when you do a multiple choice, you have to say, what is the most common answer? And the most common answer for this kind of pain is the C3-4 level. Okay, question number 8. The C4 nerve partially innervates the deltoid in what percent of patients? Is it 0? Does a C4 nerve ever innervate the deltoid? Is it 5%? Or is it C, 30% of the time? We all know it's the C5 nerve that innervates the deltoid. But does the C4 nerve ever innervate the deltoid? All right. Let's see what you thought. This comes from Tubbs. And Griffin, I think you told me who Tubbs was, that I always thought Tubbs was a neurosurgeon, but actually Tubbs was the PA for a guy. And when the guy retired, I think, Griffin, you said that he got very interested in anatomy, and he started doing all kinds of things, publishing a ton of stuff. And
Yep.
because he
Yeah.
published in the Journal of Neurosurgery. Is that right, Griffin?
It is. I believe it's the same guy who's actually involved with a lot of the Seattle Science Foundation stuff. So I don't know if you guys, if you're here, I have to imagine you've explored other virtual learning options, and the Seattle Science Foundation do have some excellent things, and some of Tubbs's videos are great.
Yeah, so he's written a lot of great papers, and this is one of them. And what he said is that about 28% have a prefixed brachial plexus with a C4 contributes to innervating the deltoid. And in the literature, it runs from 20 to 48%. So maybe even as high as 50% of patients have some component of C4 innervating the deltoid, and that everything is like prefixed and everything is moved up one level. So that makes things very, very interesting. You know, we are all taught what the brachial plexus looks like. We all have to memorize it, and we're all taught it's C5, 6, 7, 8, and T1 for the brachial plexus, but it shows you how varied human anatomy is. Okay, which nerve affects grip strength? And anybody who trains with me would know the answer to this question, because I do a dynamometer. This is like a $20 dynamometer on Amazon. And I use it on every patient every time they come in, because then they have an objective measure of what the left versus right hand is. You can also see how reproducible it is. So if somebody's malingering and first time they squeeze, it's 90, the second time it's 50, and the third time it is 20. Well, it's so much all over the map that that's likely to be malingering, as opposed to the average person is going to get within 5 or 10 pounds of their grip. So the first one was 50, the second one might be 60, but it's not going to be 90. So it just means they gave a sub-maximal effort with one of the things. And then the right hand, if you're right-handed, should be about 10 pounds stronger than the left hand. So if it isn't, then you know that it's off. I saw a person today where I couldn't really tell much of a difference when I asked them to squeeze my hand, but it was 110 on one side and it was like 65 on the other side. They were both very strong, but there was a huge difference between the left and the right sides. And the dynamometer will objectively pick it up. And then postoperatively, when you see those numbers going up, you can say that it's getting better, and you can tell that it is improving. So which nerve affects the grip strength? Is it 5, 6, or 7? Is it C8 or T1? Or is it all of the above? The answer is all of the above. Any level just about can give you a weakness on the dynamometer. It's inexpensive. I don't know how that came to be 2,000, whatever that is. Is that pesos? It's about 20 bucks. Okay, pain from the thoracic. Pain in this area is from a thoracic level below T1. Is that true or is that false? Now, this one, you got a 50% chance of getting it right. So this is the scapula, and it's in like the bottom, maybe quarter of the scapula, and it's just medial to it. Is that coming from like a T2 level, or is that coming from above at T1 or above? Well, it's a very common area for people to complain about pain, and it is false, because it is actually due to a spasm of the muscles of C8 or T1. So this is the spine of the scapula. And if you have pain just medial to the spine of the scapula, that's almost pathognomonic for a C7 radiculopathy. It hurts right there. C6 hurts right there in the supraspinatus fossa. C5 is over the top and comes over in this area. And patients always call that neck pain. And when I was in training, we were taught never operate for neck pain, because patients don't get better if you operate for neck pain. And if you operate for midline neck pain, it will never, I mean, not never, but it's hard to get it right, because any level can cause neck pain. So you can't diagnose which level is causing the problem, unless maybe they have only one spondylotic level and you can inject it, etc. But this area is C7, this area is C6, and this is as reliable a pain map as radiculopathy that's coming down the arm. And so what you should do is every time you see somebody with a monoradiculopathy, a C7, a C6, or C5, they only have one level, ask them where their neck pain is, have them point to the interscapular region, and then after you do the surgery, ask them if that pain went away. And if it did, you know, you confirm for yourself that what I'm saying is true. I saw two patients today, one with a C6 and one with a C7 radiculopathy. They both exactly right on the money. Right here, pain right here, C6, pain right in this distribution. It's very, very common, and you'll see it all the time. So the answer is when it's down there, let's go back. So when it's down here, it is a C8. So C7 is here, C8 is about here, and T1 is about here. So pay attention to that, and you will, most of the time when I started my practice, somebody said neck pain. I never said, well, where is your neck pain? Now I say all the time, show me what you mean by neck pain. And 99% of the time, they're not talking about midline or bottom of the spine. They're just talking about upper trapezial pain, interscapular pain, and that's much more localizable.
Hey, Dr. Riew?
Yeah.
I've noticed a lot in my postoperative patients, whether it's, single level ACDF or extensive, posterior cervical work, that postoperatively they'll have a transient interscapular type pain. Do you see that as well? And what's sort of the etiology behind that?
Yeah, so I think that's foraminal stenosis. So what happens is you take somebody and you hyperextend their neck to make their ACDF lordotic, and they wake up with severe pain back there. First of all, the best way to treat that is Valium. You give them 5 or 10 milligrams of PO Valium, like that. Pain is much better. They don't need the narcotics then. It works much better than anything else. Just PO Valium, 5 or 10 milligrams. Secondly, if you have foraminal stenosis, if you do an uncovertebral decompression, an uncinetectomy, and they have much less of that pain. Third, if you don't hyperextend them and you don't try to jack open their disc space so that it jacks open their facet joint, you won't have as much of that pain. Now, some of it is due to you're cramming that facet down like that. It's just like most people, if you tell them, hyperextend your neck, they'll say, I got some pain in between my shoulder blades. And I think that's a radiculopathy. That's why they have the pain in this area. And again, if you do a C6-7 and you hyperextend their neck and you cause foraminal stenosis, they will complain about pain just medial to the spine of the scapula, exactly in that area. So I think it's iatrogenic foraminal stenosis, and it goes away, as you know. At most it's going to last 3 or 4 weeks, but the body gets used to it over time. But it's much better not to cause that by not trying to over-distract, not hyperlordosing. And if you have foraminal stenosis, get rid of that, and you'll have much less of that pain. Griffin, you used to say that all the time. You said, oh, yeah, patients used to complain bitterly about that pain, but when you do that foraminotomy, they don't have that nearly as much of that pain.
Yeah, no question. I think, there are snakes behind every blade of grass, especially with something as straightforward as an ACDF. But, one of the things you always instilled in us is if you know where the vertebral arteries are before surgery, if they're in their normal anatomic position, you can safely expose a little bit more of that uncovertebral joint and do a little more aggressive of a anterior foraminotomy. And I definitely think that it's had a dramatic impact on the post-op pain of my ACDF patients.
Okay, so T2 affects hand function. Never. Why is this important? Because if you're a deformity surgeon and you're doing, let's say, a upper thoracic osteotomy, or you're doing a vertebral column resection, and you sit there and you go, that T2 nerve root is in the way. We know all it does is innervate the intercostal region. Let's just cut the nerve. If you cut the T2 nerve, do you ever have to worry about it? If it affects the hand function, never, then you don't have to worry about it. You can cut it all the time. Or is it B? At 5% of the time, 1 out of 20 cases, you're going to affect their hand function. Or is it C? 20% of the time, 1 out of 5 cases, it's going to affect the hand function. Because if it is B or C, you should never cut that T2 nerve root. Whereas if it's A, you can always cut it without worrying about it. So what is the answer? And the answer is, again, we go back to the Tubbs article. This is the post-fixed brachial plexus. It exists from less than 1% all the way up to about 5% in the literature. But a lot of people have talked about this post-fixed brachial plexus, and that the T2 nerve root can innervate the hand function. So there is overlap. There are people with brachial plexus plexi that start at 6 and go to T2. Some people go from 4 to T2. Some people go from 5 to T2. Some people go from 5 to 1. It's so variable that you can't just cavalierly cut any of these nerves. I bet in another couple of years, somebody will say, you know, in 1 out of 10,000 cases, the T3 nerve innervates the hand, for all I know. But that's the thing about what we do, is that we learn new things that contradict all the stuff that we learned in medical school all the time. Okay, numbness. A person presents with numbness in the ulnar 2 digits and in the ulnar forearm. It goes all the way up to the elbow. And the patient comes in and says, the last spine surgeon I saw said that this is coming from my ulnar nerve and I should get my ulnar nerve released. And then I went to the hand surgeon, and the hand surgeon said, no, it's coming from your neck. You need surgery at C8 or T1 or T1 or T2 or something like that. And this is a real life situation where somebody actually had numbness and weakness, and they'd had surgery. And the spine surgeon said, no, it's not your spine anymore, it's your hand. And the hand surgeon said, no, it's not the hand, it's the spine. So they were arguing as to which one it was. The nurse ended up suing the spine surgeon because the spine surgeon had done the procedure. And I was called in as the expert witness, and I realized that most spine surgeons really didn't know the anatomy of the hand and the arm. So this area, is that ulnar nerve territory, or is it a C8T1, or is it a T1T2 territory? And the answer is, if you cut the ulnar nerve at the elbow, the only part that goes numb in the volar forearm anteriorly is this area, and dorsally it comes up just past the elbow. If you cut it at Guillen's canal here, then you don't get this part. So that's how you know whether it's a cubital tunnel syndrome or Guillen canal, by seeing if this little area is numb or not on the back part of the wrist. But the ulnar nerve has nothing to do with innervation here. That area is innervated by the medial antebrachial cutaneous nerve. The medial antebrachial cutaneous nerve doesn't go behind the elbow, it goes in front of the elbow, here and down. And that medial antebrachial cutaneous nerve comes off before the ulnar nerve does in most brachial plexi. And therefore, cutting the ulnar nerve does not affect numbness in the forearm. It's a medial antebrachial cutaneous nerve. And guess where the medial antebrachial cutaneous nerve comes from? Is the C8T1. So the C8T1 gives rise to the medial part of the median nerve, part of the ulnar nerve, part of the medial antebrachial cutaneous nerve. So if you have numbness in the forearm as well as down here, it is more likely to be C8T1, because the only other way to get numbness both here and here is to have two different nerves, the medial antebrachial cutaneous nerve and a cubital tunnel syndrome simultaneously. And Occam's razor says parsimony of diagnoses is more likely you got one neck problem than two arm problems. Number 13, Horner syndrome. Is it related to a cervical root or cord? If you say no, then the answer is A. Is it due to a C8 or T1 radiculopathy? Can it be due to that? C, can a C4-5 cord compression give you Horner syndrome? And D, both B and C, C8T1 radiculopathy or a C4-5 cord compression can give you a Horner syndrome. And the answer is D. Both B and C have been reported because the sympathetic nerve can come out down in the thoracic region, or it can be impacted by a cord lesion at the C4-5 level. Both have been reported and described. I've seen two people now with Horner syndrome due to the cervical spine. One that got better and one that has not. So that does happen. Sensory distribution. If you have numbness in this area, in the anterior neck, now I used to say to people who had numbness in the anterior neck, well, no, that's got nothing to do with the cervical spine. Well, I was wrong. They say half of what you're taught is wrong, and half of what I teach is wrong. I just don't know which half is which. It's just up to my former fellows to figure out what I've been lying about half the time. So this area, is it a C1 nerve root area? 2, 3. Is it C1 and 2? Is it C2, 3? Is it 1, 2, and 3 that gives rise to sensation in this area? Now, it's very rare for somebody to complain about numbness down here, but you do see it like 1 in a few hundred cases. So as I said, numbness is extremely rare in that area, but when you do see it, it's most commonly a problem with the C2 nerve root or the C3 nerve root. First of all, the C1 nerve root, you usually don't even see a C1 nerve root pathology, but it's an upper cervical nerve root problem. So if you see somebody with a C1-2 osteoarthritis and collapse, they can manifest as this very rarely. And a C2-3 radiculopathy can also give you some numbness or pain in this area, and you should be cognizant of that being a possible etiology. This is a very common problem. This is a problem that vexes all of us. Is this a shoulder problem or a neck problem? The shoulder surgeon does an operation, the neck surgeon does an operation, and afterwards they have a problem. And the shoulder surgeon says, oh, it's the neck guy's fault. It's a neck problem. And the neck guy, of course, says, oh, it's a shoulder surgeon's problem. It's a shoulder problem. So let's look at this very, very carefully and tease this out. It's a 75-year-old who has an inability to abduct the arm. Their shoulder external rotator is 3 out of 5. They can barely rotate that shoulder externally. Internal rotator is weak, but not nearly as weak. Otherwise, all the other motor groups, all the other sensory exams are completely normal. Assume that they only have one problem. It's not both the neck and the shoulder. It's just the neck or the shoulder. Or have I not given you enough information to tell? Do you need some other scan to be able to tell? And if so, what scan? Should you get an EMG? Should you get, another MRI or MRI of the shoulder? Can you tell based on what I have told you whether this is a neck or a shoulder problem? Remember, external rotator of the shoulder is weak, internal rotator is a little bit weak, but otherwise, every other part of the neurologic exam is normal. In other words, their biceps, their triceps, wrist extensor, flexor, sensory is intact. All right, let's take a look and dissect this one at a time. So what gives you deltoid weakness? If it's the neck, it's a C5 palsy. If it's a C5 palsy, nobody ever sees a C5 palsy where the biceps and the supinator, which is the lateral head of the biceps, is completely normal. They always have weakness of the biceps and the supinator. So since this patient did not have weakness of the biceps and the supinator, there is no way that this can be a cervical spine issue. It's got to be something other than the cervical spine issue, and that's how you know this is not a cervical spine problem. Just remember the overlap of the myotomes, that if you have weakness of the deltoid, you must also have weakness of the biceps. If you have weakness of the biceps and there's no weakness on anything else whatsoever, even a tiny amount, it's not a C5 problem. You can't have a C5 palsy in 99.99% of the cases unless you have weakness of your deltoid. So by process of elimination, you know this is a shoulder problem. And this is a classic massive rotator cuff tear in an elderly person. And so if you suspect a rotator cuff tear, test their biceps and supinator. Unless they have a massive biceps tear, in which case they have a Popeye upper arm. That means that the biceps tendon is torn and their biceps look very large on that side. You can diagnose that biceps tendon rupture very easily. But most biceps tendon ruptures, eventually the strength is fairly normal anyway. So that's how you tell if somebody has a massive rotator cuff tear. Now, of course, you can get an MRI and diagnose that also, and you should to confirm it, but this exam alone should tell you that this is not a neck problem. Okay, weakness, we're down to the last two questions. Weakness of which of the following is likely due to something other than a radiculopathy? So if you have a finger adductor weakness, is it likely that it is due to something other than a radiculopathy? And in other words, can a radiculopathy give you weakness of the finger adductors? How about shoulder external rotator? If you see a weakness of the shoulder external rotator, can that be explained due to a radiculopathy? And finally, a shoulder internal rotation. So if you have weakness of the shoulder internal rotator, is that something that you can see commonly with a cervical radiculopathy? Which of these is the one that you're least likely to see with a cervical radiculopathy? If you had to choose one and say, well, I don't think that's due to a cervical radiculopathy. Is it finger adductor, external rotator, or internal rotator? Now, I always check external rotator, internal rotator on every single patient that comes in. I do a motor exam. I start out with the deltoid, the biceps, the triceps. I have them supinate, pronate, internal, external rotate, wrist extensor flexion, finger abduction, finger extension. I have them do an opponens, abductor pollicis brevis, flexor pollicis brevis, and I check all of those things. One of the things that I check for is, I mean, in addition to all of these things, so one of these, if it is positive, if they are weak with one of these, I know that it's not likely to be a neck. So I'm looking for a negative test. And the answer for this is this. Finger adductor is due to palmar interossei. So you remember that by you catch rain by putting your fingers together and you put your hands up. So it's a palmar interossei that allows you to do that. And if that's weak, it's very common. You see it weak with CAT1. So you see that with radiculopathies all the time. Also, shoulder external rotator is very commonly weak with a C5, C6 radiculopathy. So if you have somebody with deltoid weakness, they're going to be weak in their biceps and they're going to be weak in their shoulder external rotator muscle. However, shoulder internal rotators are innervated by so many different muscles, and there's so many muscles that go into it. It's your anterior deltoid, it's the subscapularis, it's the teres major, it's the latissimus dorsi, and it's the pec major. And they're innervated by C5, C6, C7, C8. In other words, you almost never see weakness of the shoulder internal rotators as a result of a cervical radiculopathy. It's either due to somebody who has like a severe rami brachial plexopathy, or they got a massive rotator cuff tear that's causing weakness of their internal rotator. It's extremely rare to see somebody with an internal rotator weakness, but if you see somebody who's weak with internal rotator, they're weak with extension, flexion, biceps, triceps, grip, finger abductor, adductor, and their MRI looks fairly normal, this person is malingering. Because if they don't have a shoulder problem and they've got a minor problem, they're just not bringing their arm in. And if you look at them and they have no atrophy, now if the entire arm is profoundly atrophied, yeah, it's likely they got a brachial plexopathy. They had their, traumatic brachial plexopathy where they had a stretch injury to every nerve. But if they don't have severe atrophy and they have internal rotator weakness, it should clue you in that the person is malingering or also has a significant tear of the rotator cuff. And the way you diagnose it, obviously, is you get an EMG nerve conduction study and you get a shoulder study. So shoulder internal rotator is what you're looking for. You want to see that as being normal in almost, you see patients with profound radiculopathy of C6, C5, C7, C8, and all of them should have pretty normal shoulder internal rotator unless they have polyradiculopathy or they got cord compression causing a profound myelopathy. Okay, last but not least, patient has only the following weakness, numbness, and pain. Is this a cervical radiculopathy? You got a 50-50 chance of getting the last one. Is it yes? This is a cervical radiculopathy, or B, no. They have weakness of the distal phalanx of the thumb flexion. When you ask them to make an okay sign, all they can do is do this. They can't get their fingers together like an okay sign. They have weakness on pronation. They have numbness in the thumb, index, long, and part of the ring finger. And they have pain in the radial distribution and the thumb and the radial ventral forearm. Is that due to a cervical radiculopathy, or is that not due to a cervical radiculopathy. So which is much more likely, that it is or that it is not? And people fall into the trap all the time. If you don't examine the patient, if you don't do a pronation test here, if you don't check the distal phalanx of the thumb, if you don't test all of these things, you're never going to know, and you're going to operate on the wrong part of the body if they have significant weakness. So let's go to the answer, the rationale. This is a pronator Terry syndrome. If it were radiculopathy, you'd have to have the C6, the C7, the C8, and T1 nerves all weak in order to give you weakness of the flexor pollicis longus, which is what allows you to do the OK sign. You'd have to have flexor digitorum profundus, that's also weak. You have to have the pronator teres and the pronator quadratus all weak to get weakness of pronation. And you have to have the median nerve area numb, and you have to have pain. And so that's a C6, C7. And so you have to have all of these. So if you see somebody who can't make an OK sign, they have weakness of their thumb, they have weakness of the flexor pollicis longus, the profundus, and their pronation is weak, and they've got numbness and pain distribution. What they need is a proximal median nerve release underneath the pronator teres. That's what's causing this issue. It's not the anterior interosseous nerve, which also gives you the inability to do an OK sign, because there's no numbness, there's no pain in the forearm, and there's no pronator teres weakness if you just have an anterior interosseous syndrome. But that's up to the hand surgeons to distinguish that. You just need to distinguish and know that this is not a cervical radiculopathy. But I've seen people fooled by this and do a C5-6 ACDF on patients who had a pronator quadratus syndrome, and it was misdiagnosed as being a cervical radiculopathy. So the answer is no, this is not a cervical radiculopathy. This, in fact, is the pronator quadratus syndrome. So in conclusion, anomalous anatomy is very common. You have to localize their pain by asking them where it is, and you really have to know your anatomy. You can't just know the cervical anatomy. You got to know the shoulder anatomy. You got to know the forearm anatomy, and you got to know the hand anatomy to a certain extent so that you don't make mistakes. And let me tell you, I have made plenty of mistakes. So the reason that I know some of this that I know now is because either I made a mistake, or I made the wrong diagnosis, or I learned by trial and error, or a fellow taught me an answer to something. So keep your eyes and ears open and know that half the stuff that you were taught is really a lie, including maybe half the stuff I taught you today. So thanks so much for your attention.
Dan, that was absolutely fantastic. I think this has been very enjoyable. Probably the worst part of that was my failure to get the polling to work, but we've had I think plenty of interaction here in the chat box. I have two questions for you while we see if anyone else from the audience has any questions for you. But I think the name of the game is level selection in the cervical spine, and so I'm going to ask you about two adjunctive tests. The first one being EMG nerve conduction study. Can you tell us how you use it, how you interpret it, and what is your threshold for getting it on a patient where you're trying to decide which level to do? Yeah, so a lot of times, I would love to tell you that the anatomy is perfect like this and you can make a diagnosis every single time. But we all know the truth is far from that. We see somebody with a C7 radiculopathy and they don't have the exact area of the numbness, doesn't go all the way up the forearm. It's only like one finger or something like that, and we're not sure. And we do a Tinel's on the wrist, and they go, yeah, I think that's causing some tingling. Or you do a compressive phalanx, and yeah, I think that's causing some numbness. Or you pound on their elbow, and they think I got it. You pound on their neck, and yeah, I think that's causing. So in those situations, I think an EMG nerve conduction study does help. Understanding this, that a positive EMG, so if you have real disease, an EMG sensitivity is only about 85% in the best of hands. It'll miss 15 to 20% of issues. If it says that there's some problem there, it's 95% specific, so it really is there according to what the electromyographers say.
The other interesting thing about this is this, that I didn't know for years until an electromyographer taught me this. He said, if you suspect, let's say somebody presents with just numbness, they have no motor weakness whatsoever, and you send them for an EMG nerve conduction study, and they have this big, huge disc herniation in their neck, and you go, okay, that's going to be positive. And they say, EMG nerve conduction study is completely normal. There's nothing wrong. And you go, how can there be nothing wrong? They got dense numbness in their hand. What you're doing with that nerve conduction study is you're just ruling out that that numbness isn't due to a nerve conduction. So they, let's say to do carpal tunnel, they see how fast it conducts across the carpal tunnel. If that's normal, it's saying that the median nerve there is normal. Now, a nerve conduction study in somebody who has a cervical radiculopathy causing numbness can be normal. And the EMG part, which picks up, fibrillations in the muscle, if it's not affecting the muscles, it can be normal also. That's why it won't pick it up. So just because if you say that they've got dense numbness and the nerve conduction study is normal, that's pretty good evidence that it's coming from the cervical spine. So that's why I get EMG nerve conduction studies when I can't tell, or when I'm pretty sure they have a double crush. The reason I want to get that is that if they have a hand and a neck problem, and the neck problem isn't severe, I send them to the hand surgeon to get the hand released first. Why is that? Because the second surgeon that cures the problem is the one that patient always thanks more. So if you do the neck and they still have hand numbness, and then they got to go see the hand surgeon, and the hand surgeon takes, and then the numbness is gone, they say thank you to the hand surgeon. He goes, that bum, he operated on my neck for no good reason. I should have come seeing you first. Whereas if the hand surgeon goes first and they still have numbness, now you cure them. Now they're giving you bottles of wine. They say you're the greatest and all of that stuff. You get all the credit despite the fact that they had a double crush. The other thing is, this is so much easier that if they do a little tiny thing and you get better with that, then they say, wow, you saved me an operation. My hand's all better. I feel great. And even though you may think that they've got a double crush, it may be 90% this and 10% this. And you save them a neck operation by doing that. But for all of those reasons, it's much better. Now, if you're positive they have both, sometimes, I have done a few cases where the hand surgeon does this under a local anesthetic and I do the neck the same day or the next day. And I think that's perfectly reasonable also. But those cases, you'll see have an EMG that says patient has profound radiculopathy, profound, denervating carpal tunnel syndrome or something like that. So I think those are very important studies. And a brachial plexus MRI, there's a guy at HSS, I forget, he's a neuroradiologist who specializes, who's written a lot of papers on brachial plexopathies, that he diagnoses it based on the inflammation there. So I often will send patients to him to get the MRI there and to make the diagnosis, because he's world-renowned for being able to pick that up. And I've had a couple of patients that he's actually diagnosed.
That's great. And then, one of our co-hosts, Wendy Gibbs, is a neuroradiologist at Mayo Clinic, and she's quite active. She does a lot of interventional procedures. So one of the things that we've all talked about as hosts, and we're trying to come up with a second session, is about some of the interventional procedures. But can you comment on how you interpret either cervical epidural steroid injections in response to it, or any selective nerve root blocks that you would order and try and interpret in the cervical spine?
Yeah, they're great tests. I used to order them all the time. When I first started out in practice, it was in St. Louis 25 years ago, and nobody in St. Louis was doing these blocks. And I read an article in some journal article that these Japanese guys were doing a transforaminal. And the way they did it was they would go in from the front, they would hit the vertebral artery, and withdraw, saw that they were in the vertebral artery, went through to the other side of the vertebral artery to localize they were in the right place, and then injected. And I said, oh my God, that sounds crazy. And so I talked to our radiologist, and the guy said, yeah, I think we can get it from the side. So he started doing these blocks, and he was the first one in St. Louis to do them. And he and I actually wrote a paper on 1,037 transforaminal epidurals without a complication. And he helped me to diagnose, and a lot of stuff I know about localization comes from those diagnostic blocks that he did, because I would send the patient that I thought, okay, they got pain here. Let me see what level it's coming from. he would do the blocks, and I would say, okay, so this pain got better immediately, and we had these pain diagrams, and we had the patients fill out the pain diaries to know when it got better. And that's how I learned about a lot of where the pains are. And then there were a lot of articles written about how dangerous it is. And we did a study on particulate steroids where we injected pigs, cannulated the vertebral artery, and injected particulate and non-particulate steroids, and found that all the pigs that got particulate steroids died. They embolized into their cerebellum, and it killed them. But none of the ones that we injected Decadron. And so we said, you need to put non-particulate steroids. And then I was part of a group that was headed by a guy named Rathnell, who's at Harvard Medical School. And we, for the the FDA, came up with some recommendations about what to do. And most people said, we don't want transforaminal epidurals in the cervical spine. They're too dangerous. I really fought hard to say, I think it's a very good diagnostic tool. And so I do get them. They are a good way to diagnose. If you're not sure, I do get them, but I get them a lot less frequently. First of all, there are so many of the injectionists in New York City don't want to do them. So I send them for a transforaminal, and they end up with a facet block, or they end up with a central epidural. And, they talk the patient out of it and say, it's so dangerous, because there are a lot of articles that talk about how dangerous it is. I know a spine surgeon who used to do these injections, and he doesn't do them anymore. He doesn't even do epidurals anymore. He only does facet blocks because he had a complication. But they are a very nice way to make diagnoses. But they are dangerous. But I tell them, listen, I think you got to go to the person who says they're good at it. They do nothing but this. And their complication rate is what you want to hear about, not what the general complication rate. Wendy, what do you think about those blocks?
So I was just writing in the chat box as you were talking a little bit. And also my colleague Peter Krantz, who was one of our guest hosts not too long ago, who's an expert on cervical epidurals, has done so many of the papers from radiology on this, is also here with us. If you do it under CT, we can do it safely. We can see what's there. We always use Decadron. The places I have been, everywhere I've trained, nobody ever wanted to do them for the reasons you said. Everybody thinks they're too dangerous. But if you use non-particulate steroids, I don't know that there's ever been, I don't know if you said this, but there's never been a case of stroke with Decadron that I know of. You do have to worry about dissecting the vert, maybe. We don't want to hit the vert. But again, with CT, we can see them. So we have them supine on the table. I do have colleagues that are a little bit older that do them under fluoro still, and they're so good. They've done thousands and thousands. My friend Blake Johnson up in Minneapolis, they can still do them under fluoro safely. But I think in general, CT is the way to go, which means you have to send them to radiology.
Yeah.
So, but yes, it's a great test. I get referrals from neurosurgery for these all the time. That's the main procedure I do now for kind of preoperative planning for the neurosurgeons.
So Dan, one of the things that we've discussed as a group, and also with Wendy, since she's our resident expert neuroradiologist, are, just the objective characteristics of congenital stenosis, and also how to quantify neuroforaminal stenosis. Maybe you can give, just kind of your 30-second take, and then Wendy can tell us her take, and I think it will be interesting for the audience, and then we'll kind of finish up after that, since it's just after 6 o'clock Eastern time.
So we just finished writing an abstract for CSRS on stenosis, and we were following a whole bunch of patients with asymptomatic stenosis, and I don't recommend surgery for them, as you know. And what we found is that if you have a canal size less than 7 millimeters, about half of them end up developing myelopathy over time. I still think most of them should be left alone. You just counsel them. When you develop myelopathy, then come back. That's the patients without cord signal change, without myelopathy. If they have radiculopathy, the consensus opinion in the group that I was part of, that Michael Failings from Toronto was the lead on, if you have radiculopathy and you have stenosis, as per Bednarik's data, you should counsel them that surgery is an option, or you can just do close monitoring. So 7 millimeters would be a good cutoff, I think. If you have radiculopathy and stenosis, you should counsel them. You're highly likely to develop myelopathy. You can either have surgery now or wait.
Wendy, what's the radiologist approach?
Yeah, so I actually put up a tweet about this before the session, just so people could look at it if they were online. I never use numbers ever, and 7 is actually the smallest number I've ever heard. So that's really interesting because I've heard 14, I've heard 10, and I put up a radiology paper from a couple years ago, the journal Radiology, where they did measurements for different heights, sex, age. Everybody's very different, so I think it's very hard to have a one cutoff. So what I always tell my trainees, everybody actually, is that I know it when I see it. So if the person is younger, they have stenosis without having too much degenerative change. So if they have like core compression with hardly any disc bulge, that means they've got congenital stenosis. To me, you can tell by the look of it. So yeah, so I'm really glad to hear this number of 7. Like I said, I've never heard that small of a number. I think radiologists, I just read a textbook a few hours ago just to check on that. One of them, the main textbook we have, says 14, which is much bigger. So again, I think it depends on the patient. I'm sure you would say it depends on who you're dealing with as well.
Yeah, I want to clarify one thing. 7 millimeters. So we followed anybody who had a canal size that was less than 14, because that is, and the reason that less than 14, that means 13 and smaller. The reason that number has come to mean stenosis in the cervical literature is that the core diameter, anterior to posterior, is about 10 millimeters. You need 1 millimeter in front for the dura, 1 millimeter for the dura in the back. That gets you 12 millimeters, 1 millimeter for CSF. And so that's your 13. So if you're at 13 or less, then you have barely enough room. But when we took all those 13 millimeters and said, which ones are more likely to develop myelopathy? Because most of those patients are asymptomatic. And asymptomatic, we did a study a long time ago that showed that 29% of Americans have stenosis less than 14 millimeters. So yeah, it's narrowed, but so do 29% of Americans. So you wouldn't operate just for stenosis. So I agree that the radiographic diagnosis of stenosis should be up at 13 millimeters, but in terms of which one are more likely to become clinically relevant, we found it was less than 7 millimeters, had about a 50% chance of developing. None of them became quadriplegic. They all developed it slowly. So just because you got stenosis, and I had patients that I was following with 4 millimeters of space available for the canal, non-operatively and with observation. And the total patient years was something like 250 or maybe 500 patient years, because we had like 150 people that we were following with stenosis. And some of them had 15-year follow-up. So it was a very long follow-up. And it matches what Bednarik has said, that you shouldn't operate asymptomatic stenosis.